All right, so now we're going to talk about the labs and also talk about medications. It's probably the most confusing part of diabetes. Medication is just kind of hard, but I kind of pointed out a few of the processes and how it works. So that should help you understand the medications. When we talk about labs, it's all over the place. It's not really all over the place, but they make it super hard. Endocrine, as you'll find out in MedSearch 3, is extremely convoluted, and they use different names, different things, but it's all the same. But either way, the best test from this whole thing is your A1C. So A1C is that rightmost column there. A1C is going to be the test that is going to tell you your last 3 months of sugars. All right. So here we got A1C right there. That's the best test. Is 3 months worth of sugar levels. So if your A1C is good, right? If A1C is less than 5.6, so good in green here, color coded it for you guys. So it's less than 5.6. That means your sugar on average was about 70 to 100, right? That's a normal sugar, right? So you can see here's poor control, right? A1C at 9. That means my sugar is 215 at baseline, right? My A1C is 14. My sugar is 380 at baseline, right? They're walking around with a sugar of 380, right? So for the last 3 months at least, right? So we want to check the A1C as like an outpatient. If someone gets diagnosed with diabetes, making sure they're doing the best thing to take care of themselves, we would look at the A1C every 3 to 6 months or so, right? There are other ways to do it. When you get to OB and women's, that's what you can do. You'll hear about the oral glucose tolerance test, which is ridiculous, right? Some of you have gone through it. It's not fun, right? So that's looking at what's your baseline sugar and what's your sugar after we give you glucose, right? There should be a normal response. You should release insulin. You should have a response to it. If you don't have a proper response because you don't have enough insulin, your sugar might be too high. If it's greater than 200 for 2 hours, for 2 checks, then you have diabetes. Congratulations. You have gestational diabetes at least. All right. And then random glucoses and fasting glucoses, those can be done as well. When you're right now not eating, then your sugar should be less than 126. All right. So not eating for like 6 to 8 hours. So over here, MPO times 8 hours, then we check your sugar. If that sugar after 8 hours of not eating is more than 126 twice, like you have to do it again the next day or in a month, then you have diabetes, right? What if it's just random glucose? If it's more than 200 times 2, right? And you have some symptoms of diabetes, like you have a non-healing wound, you have vulvovaginitis, you have all these different symptoms of diabetes, and you have a sugar more than 200 times 2, you have diabetes, right? But again, the A1C is the best one. And when do you have diabetes for A1Cs? More than 6.5%, right? You only need it once. You don't need to do 2 tests, 3 tests, 4 tests. One time, more than 6.5%, diabetes, okay? End of story. If you're 5'7" to 6'4", you have pre-diabetes. You better change your ways so that you don't develop full-on diabetes, right? And then, again, that's 120 days or 3 months worth of, 3 to 4 months worth of good glucose control. Right? A1, so it's like, yeah, I watch my sugar, I take my insulin every single day. It's like, with your A1C, the results say, right? That's not exactly true. Okay? So what it literally is doing, what glucose does, just like when you put a stick into a hyper-concentrated glucose solution, it will attach to that stick, and it's what you're eating right now, right? That is called rock candy, right? So rock candying is where the glucose, when it's in super high concentration, it's going to start to crystallize on things. It's going to start to come out of the substrate, right? It's going to, what's the word? Not decanter, but it's going to, what's what I'm looking for? Can't think of it. It's a chemistry term, where it comes out of the solution, precipitates. There we go. All right, thank you. So it precipitates out, right? So when it precipitates out, it's going to crystallize to the walls of the vessels, right? It's going to crystallize to the myelin sheaths and to the nerves, right? So those are going to result in your chronic complications of neuropathies and your chronic complications of coronary artery disease and chronic kidney disease and stroke and such. All these are a result of the crystallization, right? And it's also going to crystallize to your hemoglobin. So we measure the crystallization of your hemoglobin, or glycated hemoglobin levels, your A1C. That's literally what your hemoglobin looks like down there, right? It's crystallized with glucose, and we can look at 3 months or 3 to 4 months worth, because an RBC lifespan is 3 to 4 months, right? So you can assess how good their glucose is control based on how hyperglycemic they are. The more hyperglycemic they are, the more percentage of their hemoglobins are glycated or rock candied, okay? So that's the idea behind A1Cs. And A1Cs have a lot of different numbers attached to them, where the big one is, do you have diabetes or not? And your goal for when you have diabetes is to get it under 7%. you would think, well, if I have diabetes, I want it under 6.5%, or I want it under 5.6%. But then they find out these patients get hypoglycemic, so it's not great, right? So as long as they're under 7% for diabetic, that's great. But when do you have diabetes? When you're greater than 6.5%, right? And we'll talk about insulin therapy in a minute, okay? So that's the idea behind our diagnostic tests. Our A1C is really where it's at. Right here in yellow is our fasting sugars or our random sugars. If you have a random sugar over 200 times 2, you have diabetes. If you have a fasting sugar, which when you do an oral glucose tolerance test, you fast for how many hours? About 8 hours, right? And then you can, right there, if your sugar is over 126, you can just end the test. Like, guys, I'm done. I'm not going to drink that solution, okay? We're done. And then you can go through the whole test. It takes 2 to 4 hours, and you can see if your body has a natural response to a glucose load or not, right? The other piece with this is, again, remember our insulin and our glucagon will keep our sugar about 70 to 180, 70 to 200, 80 to 200, somewhere in there. Even the American Diabetic Association can't agree on what exactly it does, but that's kind of where you're going to keep it, right? And insulin, you give insulin to patients usually to keep their sugar under 180 or so, right? And then up here in blue, top middle, that's your different Latin you have to know for insulin dosing and insulin stuff, right? You have sub-Q, but is it given anti-sebum? Is it given AC, right? Is it given at the hour of sleep or ora somni, right? So that's HS. So AC and HS is usually the recommendation for how often we check our sugar and when we could give glucose coverage, right? And we'll talk about prandial. Prandial is just a fancy word for mealtime, right? So take your insulin with meals, right? Take your PO diabetic medications with meals. There's preprandial and postprandial, right? There's basal, which is your baseline insulin, what's always circulating inside your bloodstream. And when we talk about insulin coverage and insulin types, we're going to be manipulating those words. All right, so treatment overview. So this, again, type 1 diabetes, you can't coddle the situation. You need to replace the insulin. There's no other fix. They don't make insulin, so we got to replace it, right? And you're going to mimic the pancreas. So you're going to mimic what the pancreas does. The pancreas produces a little bit of insulin at all times. That's called your basal insulin. And then it produces insulin whenever you have a meal, right? When you have a meal and you have a glucose load, insulin gets released, and insulin is going to then take that glucose and do what? It's going to store it away as glycogen. It's going to take those lipids and store it away as fat. So when someone takes insulin, they get fat, right? And that fatness can then cause cause worsening outcomes, right? So unfortunately, when you get started on insulin, you also gain weight, all right, because of how insulin works, okay? So you might have to start someone definitely on insulin. They're going to be on insulin, but they might also have to be on oral anti-diabetic agents. They have to be on an oral agent to also lower their blood sugar, okay? So the key triangle there for all diabetics for treatment as concerned is this little triangle of diet, exercise, and then be compliant with our medications, right? One of the big ones being, of course, insulin. And who always needs to be on insulin? 100% of the time is type 1 diabetics. Type 2 diabetics might get there, and they usually get there when their A1C is more than 9%. So we have a lot of agents to use before we get to, before we have to dive in. But automatically, if their A1C is more than 9%, we're going to automatically start insulin. You're going to see they're on insulin at home because their A1C was greater than 9%. Right? So you start with non-pharmacological. We're going to try it out: weight loss, diet, exercise. See if the A1C comes down in 3 months. But if that doesn't work, we have to progress to pharmacological. Right? And again, everybody has diabetes, so every pharmaceutical company has a medication. So unfortunately, we have to know, the doctor can prescribe any one of these 8 to 11 categories. We have to know what the side effects are and if it's safe to give, right? And we have to know how to administer it. We have to know what the side effects are, all these things. So unfortunately, we have to dose you with these medications, right? Because you have to know. If the doctor says, oh, I'm going to order empagliflozin, it's like, well, okay, well, what is the risk factors? What can happen? What's the things you should know about this, right? You should know what that medication is and how it works, okay? So the medications, these are called oral anti-diabetic agents. Again, there's many of them. We're going to try to break them down as easily as possible and categorize them to make as much sense as possible. And again, after oral hypoglycemics, then we usually start insulin. That's the next step. So after we talk about all the PO agents, we're going to then talk about insulin, the different types of insulin. Okay, and we mentioned insulin is going to make you gain weight. That's not great for a type 2 diabetic. The medications that are best on here are the ones with not other under the other category that make you lose weight. That's great, right? If I lose weight and it fixes my diabetes, controls it, that's perfect, right? If I have a medication on there that makes me gain weight, that's probably not a great medication. Okay, and of course the medications that are good are super expensive, and that's America's America. All right, and then we have surgical. So last thing, we might do pharmacological, we might have good control of our diabetes, we might then go through surgery. What kind of surgery can I give for diabetes? Do I get a pancreas transplant? No, you get a bariatric surgery. You do bariatric surgery to take away the weight, which is contributing the adipokines and the interference with our cells and with our pancreas, right? So bariatric surgery can heal by 83% of diabetics. But it's a vigorous program. You have to follow all the rules. You have to show effort, and it's not for everybody, right? It has its own complications too. All right. So going back to the oral anti-diabetic agents, the oral agents here, everybody and their mom is on metformin. All right. Metformin is a very, very common medication that's tested very frequently. It is a medication that almost everybody can be on. It came out in the early 20s. It's a medication that's been around for forever. So everybody knows it. Everybody tests on it. And what it does is it works the liver and tells it to stop breaking down lactate, stop breaking down pyruvate. So it tells the liver to stop glycogenolysis, right? So it stops the excess glucose production. It also interferes with glucose absorption in the gut, so you get some GI symptoms, right? So we get some GI symptoms with this. And again, this chart is an overview for the next 3 slides. The next 3 slides go into more detail on each one of these medications. But metformin, again, that's just to highlight that one. That's one that's going to have be there almost always. You're always going to see metformin, except when they have what? CKD. Chronic kidney disease is a contraindication because metformin levels will build up and cause problems. Usually the problem is lactic acidosis, right? And then contrast procedures. That's also a big red flag if someone's going for a contrast study. And what's a contrast study? What's an example of a contrast study? Like a CT scan that uses contrast. So CT angio, right? Go in the cath lab with contrast. All these things are they on metformin? I should hold it. How long should you hold it for? 48 hours. After? 24 hours before. Okay, so we talk about our oral anti-diabetic agents. We break them into secretagogues and non-secretagogues, right? Shalom. So secretagogues, what does that mean? Secretagogue is something that promotes the secretion of insulin. It tells the body, secrete more insulin, all right? Whereas a non-secretagogue is one that primes the body to respond to insulin. So it's a medication that will make the body respond better to insulin, okay? So there's a lot of different, you wouldn't be on the same category, but you'd be on multiple ones, like 3 to 4 to 5 agents at a time, okay? So just to highlight this table here in red, those are things you want to avoid. And yellow, weight gain, that's not good, right? And then we have some contraindications there as well. Like if they have a sulfa allergy, it's probably not a good idea to give the medications that have a sulfa base, right? And there's only one of them, which is nice. That's their sulfonylureas. So the sulfa is the clue there, right? So we'll talk about these ones in the next couple of slides. So this is your overview table that's easily tested from, all right? And I underlined the suffixes. So the suffixes will tell you what category it is, and that will clue you in, oh, this category has major adverse cardiac events. What's a major adverse cardiac event? An MI, yeah, CVA, a CAD, which is MI. You have a lethal rhythm like VTAC, VFib, right? So it's probably not good to be on that medication for if they're at risk, right? And they broke that down into what's called a MACE, a major adverse cardiac event. Okay. All right, so we're going to get deep into these, and I kind of put the abbreviation on the left-hand column. So when you look at other charts, it kind of makes sense. But basically, what we're doing is we're manipulating insulin in some fashion, or we're manipulating the cells to respond to insulin, or making the pancreas secrete more insulin. All right, so the first category again is metformin. There are biguanides, but there's no other biguanides, so it's not making sense to call it a biguanide. So metformin is metformin, and it's been around since the 20s. The brand name is glucophage. All right, so it works on the liver and it tells the liver to stop breaking down stuff that makes glucose. Right? It says not today. Stop it. Right? No more making glucose anymore. We want to control someone's sugar. Right? Their sugar's too high. Stop making sugar. So it inhibits gluconeogenesis. So that's in the liver, it inhibits the glucose production. It makes the peripheral cells more sensitive to insulin. So if someone has insulin, it makes the cells respond better to it, which is nice. And then it decreases the absorption of glucose in the gut itself, right? And that's why they might get some GI upset, some nausea, vomiting, diarrhea, and cramps, right? It does go away with time. After like 20 to 30 days, it might go away. And the recommendation is take this medication with food, okay? So lactic acidosis is rare. It usually happens when we give it in renal failure. And that is the time when you get hypoglycemia. The medication itself doesn't usually cause hypoglycemia. All right? It does not cause weight gain because it doesn't make you secrete more insulin. It just makes your cells respond to insulin. If it made you secrete more insulin, you would gain weight because what does insulin do? It stores away glycogen and it stores away fats. The fats make you fatter. All right? And then sulfonylureas are framed in lethal rhythms, right? Because sulfonylureas cause major adverse cardiac events, right? So there are a few sulfonylureas. They all start with G usually and end with ide. So G something ide. So glyburide, glipizide, glimepiride. These guys are they're super cheap. That's the problem. They're super cheap. So, and again, America, we have a lot of patients will be on this because they can't afford the more expensive medications. Okay. So these medications. So it's a medication usually given as a second line. So we give metformin, then we give this one if they can't afford the other stuff. And what it does is it depolarizes the beta cells. It makes the beta cells closer to the threshold so that the beta cells will secrete insulin much easier, right? It's going to make the beta cells secrete a lot of insulin much easier. So any kind of glucose that might drop in the gut, it's like, oh, insulin, and it's going to squirt out some insulin, okay? So it makes it hypersensitive to do its own job. So it has like a nervous trigger finger, I guess you could say, okay? So sulfonylureas have sulfa in the name, so it's going to cause sulfa allergies. And those that have, it's going to be reactive to someone who has a sulfa allergy. And what does a sulfa allergy look like? It causes what's called Stevens-Johnson. Nobody wants Stevens-Johnson. All right, it's also known as toxic epidermal necrolysis. None of those words sound nice. It causes lysis, it causes necrosis, it causes epidermal, so lysis of the skin. Right? So it's like a burn victim. So their skin gets eaten away. So that's why it's important to ask if someone has a sulfa allergy, right? So you would then not give them a sulfonylurea. All right, so it causes also why it's cheap and why it's not great is it causes profound hypoglycemia. Why does it cause such bad hypoglycemia? It's because your insulin cells are ready to squirt at any moment, right? They're going to squirt out insulin any moment, and that can make you hypoglycemic, right? So it's important to give this with meals so that they have a meal actually there to get, as calorie backup, as glucose backup at least. Okay. If they take too much of their medication, too much of their sulfa drugs, and they're severely hypoglycemic, we have a reversal agent. We have octreotide is a reversal agent in case someone takes too much of their sulfonylureas. All right. So there's an alternative to sulfonylureas. Like you really want to give them this sulfa drug. The alternative is these guys right here, meglitinides, and they end in nide, or glinide. So you have G-ide and you have glinide. So the glinide is the alternative to the sulfonylureas, but it's the same exact thing. It's exactly the same stuff, same symptoms, same side effects, same nurse interventions. I give it with what? Give it with food, right? So sulfonylureas cause weight gain as well because they're making more insulin to be secreted. Therefore, we get weight gain. All right, so metformin, that's going to be our go-to. That's usually our go-to, right? It's like you get a metformin, you get a metformin, everyone gets metformin, right? That's usually a very, very common drug. And sulfonylureas are common and usually outside of America as well because it's so cheap to produce. So secretagogues. So secretagogues make you secrete more insulin, right? It makes your insulin stay around for longer. So how do these work? So secretagogues, we got two varieties here. So these two varieties are going to potentiate insulin. They're going to prevent the breakdown of insulin, right? So when you secrete insulin, your body's going to start breaking it down, right? So these two agents here stop that breakdown. So what do we have? We have GLP-1 receptor antagonists. So GLP-1s They end in tide and glutide usually. So only one of them ends in tide, but glutide. All right, you can think of glutes, right? You can think of Kim Kardashian, because Kim Kardashian takes semaglutide, right, to lose weight. So it's a profound weight loss drug. Right? It's got its Ozempic's been on the market only about 5-10 years, and now it's a great medication to lose weight if you can afford $1,000 a month, right, to get the medication. Okay, so it ends in glutide. It's usually given sub-Q, that's a little injection. And what is the action? It's a incretin analog. So it's what an incretin is a peptide. It's a little protein that makes insulin stay around for longer. So we look here, incretins, also known as GLP-1s. These guys are going to stimulate insulin, right? And they're going to inhibit glucagon. So they are great at making insulin stay around for longer. Okay, so they're going to potentiate insulin. It's not like an insulin replacement. It's like it's just supporting your whole system, right? And because it's not insulin, it's not going to make you gain weight. So it's great in that fashion. It's like, well, I thought insulin, whether it be taken by sub-Q or if I have my own, wouldn't that cause weight gain? Well, it causes a little bit of weight gain, but it causes a lot more weight loss. And how does it do that? So it does that by, what do incretins also do? They cause, I think I put it here as well, they're going to decrease GI motility. So decreasing GI motility is great. Insulin increases GI motility. So when insulin comes around, it increases GI motility, and now you're ready for your next meal. It's like, oh, I'm hungry now. I'm going to eat more calories, right? If I decrease GI motility, I slow it down, I'm not going to take in as many calories. Therefore, I have weight loss, right? So that's how your GLP-1 RAs work, your receptor agonists, right? Or the antagonists. Either way, they are going to potentiate insulin function, but also they have the benefit of slowing down GI motility, right? And it makes you so that you don't want to eat. And what's that called when you don't want to eat? You're satiated, because your food is in your stomach, so you're satiated, right? So what is that word there? It increases satiety? No, it's satiety, all right? So it increases satiety. So it makes you not want to eat more calories, okay? So what else? So we have side effects, because GI upset, it's going to worsen what's called gastroparesis, which is a side effect of diabetes, which we'll talk about. And it causes some pancreatitis, which is not good, or thyroid cancer is not good either. So it requires some monitoring. All right, so they are cardioprotective because they make you lose weight. So that's going to help prevent MACE. And what is MACE? It's a major adverse cardiac event. Okay, so then we have these guys, DPP-4 inhibitors. So DPP-4, you can see, stops the breakdown of incretins. So we have incretins, incretin analogs, you could say, and then you have what else? You have these guys right here that stop the breakdown of incretins. It promotes your own incretins, which is nice. It's going to it's going to potentiate insulin, and it's going to also do the same thing with decreasing GI motility, and that's going to help out, right? There's like so many syllables on these guys. It's ridiculous, but the way it works essentially is promoting your own body's insulin function and promoting incretins, and incretins are great because they make you lose weight, okay? By decreasing GI motility or increasing satiety. They decrease gastric emptying. Okay, so SGLT inhibitors. So we have two SGLT inhibitors. We have the SGLT2 inhibitors, and we have this medication from the 90s, alpha-glucosidase inhibitors. So alpha-glucosidase inhibitors, they inhibit the SGLT receptor in the gut. So in the gut, they tell the gut, stop absorbing glucose. Well, if you don't absorb glucose in the gut, your glucose will go down in the serum, right? So that's going to reduce our glucose levels. That's nice, right? It blocks GI tract absorption of glucose, specifically sucrose, lactose, and fructose. Well, there's something called lactose intolerance. That's where you can't break down lactose. So these guys get diarrhea, all right? And they also get flatus, all right? Why do they get flatus? Because what do bacteria love? They love alkaline environments, they love moist environments, and they love sugar. So they are going to chew on these like nobody's business. They're super happy there, right? They got sucrose, lactose, fructose, and what are they doing? They eat that, and what do? They fart it out, right? And really, our farts are not our farts. Our farts are the bacteria that line our gut, right? Every one of us has a unique fart. There's 7.5 billion unique farts in the world. Everyone has their own milieu of farts. So, everybody loves their own brand. Otherwise, GI upset is a big problem. All right, you got flatus and diarrhea. This is a hard sell. He's like, I got a medication for you, right? It's going to make you really popular at parties. So that's one of the reasons why people don't stick to that medication. But this guy came out in the last 8 years or so, SGLT2 inhibitors, and they work on a different SGLT receptor. They work on the one in the kidneys that we talked about earlier. They work in the kidneys and say, stop absorbing glucose, right? Remember, normally those guys were taking the glucose and putting it back in the bloodstream. But now we have papaflozin or antiflozin, or not Onflo, but antiflozin is there, and that one's going to say stop, right? Stop absorbing glucose. So all the glucose is now not going to go in the serum, it's going to go in the where? In the toilet, right? So all the glucose is going in the toilet, and what follows glucose? Water. Well, shoot, now this is actually the best medication to lose weight. You're losing all the water weight, and what else do you lose? You lose fat molecules as well that make their way into glomerulus. So you not only lose water weight and lose weight, you also lose the fat molecules themselves, the LDLs, HDLs, and VLDLs, all those LDLs, or all those DLs, right? So you lose all those things, and that's great. You lose all the weight, okay? So it's definitely cardioprotective. It's actually now, you lose so much fluid that we're going to give it to CHF patients now. So you'll see a CHF patient has no history of diabetes, but they're on a flozin, right? They all end in gliflozin, okay? Of course, you have glycosuria. They're going to have glucose in their urine, right? So what do bacteria love? Glucose. So they're a high risk for UTIs, high risk for vaginitis, okay? So, and high risk for fungi as well, all right? What else? And they lose a lot of fluids, so you got to be careful to make sure they're not losing too much potassium, because everything's a potassium waste diuretic except for SEAT, SEAT, right? So what else? So yeah, so all the glucose gets absorbed, or does not get absorbed, and the glucose will pull water through it into the toilet, right? You can see these guys have the best weight loss, right? So where are they at here? I thought I highlighted it. Maybe this has everything but that one, but it has the most weight loss of any other diabetic medication. Okay, so what else on these guys? So that's our two medications that stop the glucose absorption. Are they a secretagogue? No, they're not promoting insulin at all. All they're doing is working behind the scenes to control the sugar. All right, and then we have other agents. So one of the other agents is thiazolidinediones. That's a fun one. All right, so TZDs or thiazolidinediones, these guys are an older medication that are not recommended anymore. If you see someone on it, they have a really older provider, or they just shouldn't be on it. It worsens CHF, it worsens ASCVD, it has major adverse cardiac events. It's not a great medication. It actually primes all the cells to respond to insulin, but it also makes you store away more adipose. Well, that's the problem here. If we're storing away more adipose, that's going to cause major adverse cardiac events. Okay, so then we have those other three up top. Those guys are other agents you might see your patient on. Colesevelam works on bile, right? It's going to stop the absorption of fat, so it's actually going to support the reduction in weight. Pramlintide and bromocriptine, those guys are working, centrally. They are going, like the bromocriptine is working in the CNS, and it's just stopping the SNS. What does the SNS do? Releases norepinephrine. What does norepinephrine do? It releases glucose in the circulation, so it's going to stop that. And the pamlintide works centrally also to decrease appetite. So and it also works kind of like the GLP-1s, and it stops GI motility, so it's also going to help you lose weight. Okay, so that's how those guys work. All right, so those are the PO agents. What about insulin? So when is insulin needed? 100% is needed when? And type 1 diabetics. Type 2 diabetics will get it when? When the A1C is more than 9%, usually. Also, type 2 diabetics might get it when they're in the hospital setting. It's like, I'm not taking insulin at home, but in the hospital setting, if you have a history of diabetes, you're going to be at risk for hyperglycemia. And why? Why does hyperglycemia happen when you go to the hospital? Because stress. Stress releases cortisol, stress releases the SNS, and now you have hyperglycemia, right? All right, so for DM1, DM1 for insulin therapy, we want to mimic the pancreas, so you can expect them to be on a basal insulin, an insulin that's going to be there at all times, and you can expect them to be on insulin before meals. What's that called in Latin? Preprandial, right? So preprandial insulin and basal insulin, right? Those are the two types of insulin they'll be on, right? So basal insulin obviously is long-acting. It's there for a long time. It's always there. It's always around. And we don't want it to just disappear, so we have to give it before it disappears, right? So all of our long-acting insulins, all of our basal insulins usually end at 24 hours. There's one, degludec, lasts 36 hours. But other than that, the most common one you'll see in the hospital is usually Lantus, which is the brand name, or glargine insulin is the generic name. So glargine is a long-acting insulin that will last for 24 hours. So we give it how often? Every 24 hours. You'll see some providers order BID. They're stuck in the past. It's not BID. It's given once a day, and you give it every 24 hours, right? And if the sugar's trying to creep up in the hospital setting because they're stressed, you can increase that dose, right? And then you can decrease the dose until they get back home, all right? So we have long-acting insulins. They last for a long time, okay? And then we have the rapid short-acting insulins that we're going to give pre or postprandial. Preprandial. You want to hit them up with insulin, and you want to hit them up with a meal that they're going to be able to digest, right? Within how many minutes? It depends. So if you want to have the meal ready to go in 15 minutes, if you're given the fastest acting insulin known to man, which is fast-ass insulin, aspart insulin. All right, so aspart is a rapid acting insulin. Okay, so it's a rapid, works within 15 to 20 minutes, right? And some sources say 10 to 20 minutes, but you need to have that meal like with an eyesight. It's like I walk by the trays, and I'm going to get your insulin, I'm going to get your tray, here we go, right? Otherwise, you get that, and the dietary's not there. It's like, oh, we had a problem, we had a leak, right? The fryer spilled everywhere, and the fire, what's it called? The fire hydrant went off everywhere. That happened for real. The grill had to be shut down. It's like, I want to see that CCTV of the whole grill being doused in fire retardant. Either way, we have, then now you got to make sure you have a meal available. So what if the dietary does not deliver a meal? You can give them some turkey sandwiches, right? They're going to love those. All right, so you need to have a meal available within 10 to 30 minutes, usually 15 on average for your fast, rapid-acting insulins. And then we have just one insulin that is called short-acting. Why isn't short fast and fast long? Or there's rapid and there's short. There's only one short, which is nice, and that's our homeboy regular insulin. Regular insulin, 30 minutes is when it takes effect. Okay. All the other short ones are 15 minutes. Aspart's the fastest, right? I'd like 10 minutes sometimes. But basically, within 15 to 30 minutes, you should have a meal available for preprandial insulin, right? If you're giving preprandial insulin, you should have a meal available. All right, so then type 2 diabetics. So type 2 diabetics, again, they will be, even if they're not on insulin at home, they might be started on something. They might be started on something around the clock. They might just be on sliding scale insulin, and if the sugar is still super high, they might start some long-acting insulin. It like reduces the whole sugar by like 10% or 20%. The sugar's running like 220s. Let's start some Lantus at 5 units and reduce that to like 200s, and maybe even lower. Okay, but we still have to check the blood sugar because what if they get hypoglycemic? That's the biggest side effect of insulin is hypoglycemia. So we have to recognize if a patient is at risk for hypoglycemia or hyperglycemia. Okay. What else on this? So at home, they'll be started insulin. They can be started insulin, but also in the hospital, that's where we come in to talk about sliding scale insulin. Sliding scale insulins always use rapid or short acting. That means they use one of the three rapids. What are the three rapids? You got aspart, glulisine, and lispro. These are our rapid acting medication. They'll have an S in it, which is nice. S for short, I guess, as well. And then we have our short acting. I guess that's a bad mnemonic. So we got rapid, so we got fast, I don't know. And there's only one short acting, which is nice, the regular insulin. All the other ones are rapid. All right, so one is short, that's our which insulin? Regular insulin. The other three are fast. These are all used with sliding scale insulins. These are all used for preprandial insulins, right? Sometimes they'll have preprandial like 10 units at breakfast, 10 units at dinner, and then do sliding scale insulin around the ACHS, and then have glulisine during the day, or at Q24 hours. Okay, so where should someone's sugar be in the hospital setting? It should be about less than 180, basically. That's usually they really can't agree on where it should be, but all we know is we don't want to be hyperglycemic, and we don't want to be hypoglycemic, but when we're controlling someone's sugar in the hospital, we want the sugar under 180, okay? And there's a little reminder on A1Cs and how those work, but the other piece is with your insulins, you can go nuts trying to look at Davis Drug Guide, trying to look at the textbook, trying to look at online. They're all going to have different values guaranteed for every single insulin up there. Like even that one in the top right corner says 10 to 15 or 10 to 20 or 20 to 30 or 30 to 45. Just stick to a number and stick to it, right? You're going to be close enough, right? So the table right there is kind of that's the one I'm giving you, and that's the one that makes the most sense to me. Duration, we don't really worry about as much. Really, the only time we worry about duration is maybe for like degludec, right? And long-acting insulins, we know it's like 24 hours. We really don't care about the peak. For long-acting insulins, doesn't matter. They really don't technically have a peak. They usually take effect within 30 minutes, and they're there for 24 hours, right? And then we talk about our 3 rapid-acting, our lispro, aspart, and glulisine. They work in about 20 minutes, right? 15 minutes to 30 minutes. All right, so you can say 15 minutes for this guy right here. 10 to 20 minutes, you better have a meal present, right? And it's going to last, if you're giving it with meals, you imagine it lasts like 3 to 4 hours, right? If it's ACHS, it's each meal's about 4 hours apart, you have 3 to 4 hours, cool, right? But I really don't have to know about duration for this guy or this guy, okay? What about regular insulin? So regular insulin is a little bit longer than short-acting insulin, so it's just think about a little bit longer. So it takes effect in 30 minutes. It peaks about 2 to 4 hours. The peak is important for your medications that don't have like that basal pattern where it's just there for a long time. Because during the peak is when what happens? The highest risk for hypoglycemia, right? So regular insulin, they took the regular insulin and they had they threw up their meal in the morning. Well, shoot, now they're at high risk for hypoglycemia. And then NPH is usually not used anymore, but you'll still see it used by older providers that prescribe it. We have these long-acting insulins now, which are great, right? NPH is required. It's a headache to try to figure out how they work. You have to take them twice a day, and that doesn't do good for compliance. For patients who don't want to poke themselves twice a day and take it twice a day. But they last for like 8 to 10 hours. That's how long they last. They're like half the dose or half the efficacy of a long-acting insulin. A long-acting insulin like Detamir, Glargine, and Degludec, those last for 24 hours, up to 36. But then our NPH lasts for 8 to 12 hours or so. Okay, so that's the idea with our insulin and how they last. So administration of insulin. How do you administer insulin? I think is our last slide before break, right? So our insulins, we'll come back. So how do you give insulin? So insulin is given sub-Q, right? One insulin can be given IV. Which one's that? Regular. That's regular IV insulin, right? And if you have to give regular insulin and NPH insulin, it's RN, right? So regular is drawn up first, right? It's clear over cloudy. It's regular before NPH, and you should not be giving NPH anymore, anyways. But if you do, that's the order you can't give it. You can give it as one injection instead of 2 separate injections, right? And then do not massage the site, right? Don't say, good job, you did it. All right, that's going to cause breakdown of the insulin. The insulin is only separate from our own insulin by a few little peptides, right? So that's 1 peptide, 2 peptides, 3 peptides, 5. So if you massage it, you're going to get rid of those peptides, and now it's now full-blown insulin, right? You no longer have a peak of 30 minutes, you have a peak of now, okay? So when you give insulin, it's given at 90 degrees, if 45 degrees only if they're thin. The site choice best is abdomen, then your upper extremities, and the thigh, and the butt. You can really choose any site that has fat on it, or sub-Q tissue, right? And when you choose your site, it's not a big, it's been like 15 years, but for the last 15 years, we've changed it to now, the recommendation is you don't rotate sites, as in rotate left arm, left leg, right leg, right? All you do is rotate by 1 inch, right? 1 inch each time on the same extremity. So today is arm day, right? So arm day, right arm, all we're doing is right arm and 1 inch apart, right? And how many injections are you giving? Like maybe max of 4 to 6 at the most. Do people have 4 to 6 inches of arm to work with? Probably, right? As long as you don't go over the same exact site every single time. Like, this is my site. There we go. There we go. There we go. That causes lipodystrophy. That causes scar tissue in that area and contraction, and can cause all those side effects of giving it the same exact spot every single time. So you rotate by 1 inch, right, for that day. And the next day you choose a different site. Why do you do that? Well, left arm might get some insulin, then right arm gets insulin. And what if they're doing like weights in the right arm? They're going to use that insulin much faster than the other one. You want it to be a reliable absorption, right? You don't want to, like the left arm is getting insulin today, the left arm is going to get the insulin for the whole day. So you don't have these swings in sugars. All right, so compliance with insulin. So some patients don't like to take insulin because they got to poke themselves. They got to poke themselves for the blood sugar check. They have to poke themselves for the insulin itself, right? And if you imagine someone's an ACHS and preprandial insulin and nighttime insulin and NPH insulin, that's twice a day. How many pokes is that? That's 4 glucose checks and 3 to 6 sub-Q shots. All right, that's 10 freaking pokes that they're getting throughout the day, right? Are they going to comply that much? Not if they have to pay $80, $100 a unit for every insulin as well. So that's also a ethical thing, is the expense of the testing strips, the expense of the insulin itself, not only just the actual pokes and how much effort that takes. All right. So the more often we can get someone to like just a daily insulin, and maybe like nighttime and morning, the better. There's also insulin pumps out there where they punch in how many calories they just ate, and it gives them an amount of insulin for those calories. Okay, but they have to be able to program pumps. Usually our elderly population is not as tech savvy, so it's harder to manage that. So that's why we still have, especially in the hospital setting, we're going to be doing our sub-Q insulin, sliding scale insulins and such. Okay. All right, so let's take a break and we'll come back for diabetes, exercise, and complications. All right, so diabetes, we finished all the pharmacological stuff. Great, that was hard. All right, so we got pharmacological PO stuff and sub-Q stuff. And then now we have diet and exercise, the easy part and the way to avoid medications if you're type 2 diabetic, right? So diabetes, exercise. What are some exercise stuff to recommend? And there's also rules. So when you do diabetes has a lot of teaching attached to it. So you have to know what to teach the patient. So do you have, what do you do when you're sick? What do you do when you exercise? What do you do to avoid hypoglycemia, right? So we have to make sure that they are aware of these things. So exercising muscles, all right, the muscles that are actually exercising, if you're running or if it's arm day and you're using your arms a lot, those muscles will have the most insulin sensitivity. So if you're giving insulin in the upper arm and they're working out those arms, you have a lot of insulin activity over there and they could get hypoglycemic, right? So you don't want to give insulin in the muscle group that you're exercising is the kind of the key takeaway. And what does exercising do in of itself? Remember the GLUT4 receptors couldn't make their way over to the cell wall, right? Or cell wall, we're not plants, to the cell membrane, right? So it couldn't make our way all the way up there without insulin. Well, guess we got a cheat code. We got exercise. Exercise will make it happen. So exercise will actually move those little transporters all the way to the cell membrane to actually put the glucose back in the cell, all right? So that's the great thing about exercise, and it will decrease your insulin need because your exercise is doing part of the job of insulin. All right, so what do you need? What kind of exercise? It needs to be aerobic. And what is aerobic exercise? Exercise requires oxygen. So anaerobic exercise underwater, what does that mean? What is anaerobic exercise? So resistance training, right? So things that like strength training, that like lifting weights, is not aerobic. That's an anaerobic exercise, right? So aerobic means you are walking, cardiovascular stuff, cardiac stuff. Those are things that are aerobic. So swimming, is that an example of aerobic or anaerobic? Aerobic. What about Zumba? Aerobic, right? So you want to do how much exercise to be effective? 150 minutes. It's like all in one session? No, you can split that up, right? You can do 15 minutes for each day for 10 days per week. No, that's not going to work. So how do I have to get that in there? That's like 30 minutes a day will get you there, right? You can have rest days at 30 minutes a day, right? How many days is that? 5 days, right? 5 out of the 7 days, do 30 minutes, right? Or you can do 60 minutes on 2.5 days, I don't know, right? But don't overdo it is the idea. And the idea is to get at least 150 minutes of exercise per week. And another alternative is 10,000 steps per day. So our watch will tell us, and our phone will tell us how many steps we get. It's an easy way to track how much movement we're doing. and getting more than 10,000 steps per day is a good target for diabetes. It's an easy thing to teach, okay? And then just doing 15 minutes can help you out, but it's better to do the 150 minutes. But just like 15 minutes of just of doing yoga per day or these things can improve your glycemic control, improve your sugars. What about what are some cautions? What are some things you need to teach to make sure they don't get hypoglycemic? That's usually the risk factor with exercise. Exercise is so great at mimicking insulin that they can have risk for hypoglycemia. All right, they should check their blood sugar before, because if the sugar is 90, they're probably not ready for exercise. They need to have a good sugar, okay? Have at least 100. If it's more than 100, I'm not sure what's happened. I think we're getting hacked. Our screen's getting frayed. Anyways, if you want your sugar is less than 100, they need to carb up, all right? They need to be eating some carbs. What kind of carbs? Like a egg burrito with with all the fried potatoes and such. No, they need to be doing healthy carbs, right? Healthy carbs to get their sugar over 100. Okay, and then once they'll check it again. If the sugar is good, they can go out and exercise. Okay, they should check the sugar afterwards as well to make sure they're not hypoglycemic after the event, and make sure they eat at that point as well. And same thing, you want to avoid hypoglycemia. You also want to avoid hyperglycemia. They should not exercise when they have ketones in their urine. If they have ketones in the urine, that means they're hyperglycemic, right? They're breaking down fats, and they are at risk for DKA at that point. Okay, they should exercise the same day so their body is used to it. You shouldn't take your insulin and be off schedule, and you'd be at more risk for hypoglycemia if you're not doing it the same time every day. And you want to use a partner that's going to help you out to make sure that if you pass out, they're going to be able to be there to help out. And if you don't have a partner, you need to wear a bracelet that tells you that you're diabetic and there's glucose in your front pocket or something, right? So that you can then avoid a hypoglycemic event. And then they should be hydrating because they can be polyuric and they can be dehydrated, right? And different meds. So insulin, again, we mentioned if you're taking insulin, don't give it near the muscle group that you're going to exercise for that morning or day. Okay, and then don't exercise during peak times. So if they take their regular insulin at 8 a.m., when should they not exercise? Within 2 to 4 hours of that time, right? So between 10 and noon, they should not be exercising, right? They should be exercising maybe at 8:30 after they take some snacks or something, or they should be exercising at 1 p.m., right? After the regular insulin has gone away, all right? So PO meds, especially the ones that secrete insulin, that's going to be a danger of hypoglycemia. Okay, so exercise rules, we talked about these. And again, to have weight loss, they really have to get their heart rate up to a certain peak, right? So they say, oh, I exercised 150 minutes today. What'd you do? I walked around the mall at a slow pace. Like, no, you really have to bring your heart rate up to a certain rate, and that rate being 220 minus your age. So if you're 40 years old, you should get your heart rate up to 70% of 180 or 80% of 180. So that's kind of where the target is. So if you see right here for weight loss, right? So aerobic, speed training, where am I at? So if I was speed training, but I just want to do endurance, increase fat, burn fat, about 70% of 180 if I'm 40 years old, right? What's 70% of 180? Well, what is that? It's 140 to 150-ish, right? So that's where you should be for if you're doing aerobic exercise. If you're too high up, that's usually anaerobic stuff, okay? So diet, what kind of diet should they recommend? We mentioned carbs, should be healthy carbs, should be whole grains. They shouldn't be processed in any kind of fashion. They should be as whole as possible. Rice that's whole, not white rice, but like whole grain rice. They should have as many like pastas, like whole grain pastas. That's the idea with the carbs, right? Legumes, veggies, fruits, those are all absolutely fine, okay? Low glycemic index stuff, that was all hogwash, that didn't matter. So that's not, there's no evidence behind it. All right, healthy fats. So they should take, as far as oils go, they should avoid oils or use the healthiest oil alternative, like a natural oil, like avocado oil, right? Avoid saturated fat. How do you know if an oil is saturated or not?
It is solid.
Solid at room temperature is a good guess. All right, a good answer. That's the answer. So yes, you want to make sure you're using, up to 7% of your fats should be saturated, and you usually can measure that on there's all kinds of apps now that measure that for you. But if you do fats, they should be, avocados are great, right? And mercury, lead is not great, all right? Fish do have saturated fat in them, but they also have mercury and lead, so it's like a catch-22, all right? Well, I got to eat more fish, but I also don't want to get mercury and lead poisoning. And then protein. So protein should be about 1 gram per kilo, right? And that's when you have more protein in your diet, you're going to have increased satiety, right? So you have increased satiety, that's going to make you avoid eating more, which is nice, right? And fiber is also going to help lose weight as well. It grabs the fats that you might ingest and it poops them out. All right, what about diets? What's the recommended diet nowadays? Well, the American Diabetes Association diet actually causes diabetes, so that's not great. So the recommended diets are that they've kind of revised are, Mediterranean diet is good, and a plant-based diet, which is vegan, right? Not a vegan diet where everything's processed now, right? That's why I'm fat, right? Because I eat all the vegan processed stuff. But as far as like a whole grain, whole food approach to it, that's going to have the best evidence that's going to improve your glycemic control, improve your glucose control. Okay, low fat is possible. There's also very low fat diets; those work. Low carb, like a ketogenic diet. Of course, they need to monitor the ketones to make sure they're not getting too high. That can work as well. And carb counting, that's usually for type 1 diabetics with insulin pumps. They can calculate how many carbs they need to input into their machine, so they can then get the accurate amount of insulin. It can work in type 2 diabetics, but they really have to be with the program. They really have to know exactly what they're doing. It's very labor intensive to teach this, especially if someone doesn't really understand instructions well. Okay, so plant-based diet, again, limit all the saturated fats, but try all the things that are whole food. And then Mediterranean diet is also recommended. It's also high in healthy fats, high in healthy proteins, and healthy carbs, such as our pastas and, well, not so much pastas, but it's,